Our last session for today is a panel discussion on decolonizing global health, the challenge of public health research in humanitarian settings. In this session, we have speakers working in public health and humanitarian settings. They will unpack their experiences regarding global power structures in operational research that influence current healthcare policy and decision-making processes. We have three panelists for this session. Our two external panelists are Dr. Renzo Guintu, who is the Chief Planetary Doctor for PH Lab, and Dr. Sanjuti Saha, who is a researcher with the Child Health Research Foundation. And bringing in the MSF perspective on this discourse, we have Dr. Kiran Jobanputra, the head of MSF's Manson unit in the UK. We have Dr. Farah Mantu, General Director of MSF India, who will moderate the session for anchoring the conversations together. Over to you, Dr. Mantu.
Thank you, Pooja. Welcome, everybody. And as this is the last session of the day, I hope we all have the energy, and this is something that we will make sure that we will bring in to the panelists we have for this panel discussion. Pooja did briefly introduce all of you. Just to add a bit more few lines on introduction of each one of you. Dr. Renzu has been the one who started the hashtag Decolonize Global Health movement. Dr. Sanjuti is a scientist who brings the basic science together at the intersection of public health and has a heart and communities. So we would like to hear the perspectives that come from there. Dr. Kiran is the head of Manson unit for MSF UK, is a medical doctor by profile, has been with MSF since 2007 in various capacities. So two of the panelists are obvious experts, and then I would see Kiran bringing in the MSF perspectives around this topic. Decolonize global health. We are not the only ones who are talking about it, and it's not the session that you would see happening around the globe. So we are joining those conversations because we believe that decolonize global health as a movement, how can we contribute, not only in the discourse around it, but making some actionable steps towards a future that is equitable, that addresses the power imbalances that we are all hearing about. So global health decolonization is as long as history, but 2014 Ebola crisis brought to the fore and put it at the center stage, where there were different researchers who highlighted how colonization is bringing in asymmetries in inequalities that are experienced in low and middle income countries. And it was that in 2020, we see because of the COVID, there is an acceleration around this topic because it's more and more visible that there are problems that need addressing. And if we look at the topic, it's very, very vast. And that's why we have kind of narrowed it down to research, public health research, where we would be focusing our panel discussion on. But within that, even public health research, are we going to talk about who sets the agenda? Or who is the one who presents the data? Or we talk about where do these conferences happen? Where is the capacity built around global public health? We could go in an array of directions around this topic, but because our focus is public health research in humanitarian settings, I would really bring the attention that we have experiences shared around this topic. Why important? Why urgent to talk about this humanitarian settings? Because these are the most vulnerable populations that we are talking about, who are already facing exclusions, either political, social, or economic, are in environments where the health structure is massively impacted or impaired. So without much ado, I would introduce and ask Dr. Renzo to share his thoughts around the journey, around this hashtag movement, and where are we today? Where do we stand?
Thank you very much, Farhat, for your generous introduction. It's great to be in another MSF event. As you know, I just jumped from another conference, this time organized by MSF Geneva. I was with Maria Guevara, James Orbinski. We were talking about the future of humanitarianism in the era of planetary health. You know, when you have climate change, all these major ecological crises, pandemics happening, what is our role? And then now I'm jumping into your session about decolonizing global health, which I think is very much interconnected. At the end of the day, they're all threads in the same story. How do we actually change the paradigm that that underpin the way we operate, whether it's in the humanitarian sector, whether it's in global health or in public health research? I think there's so many threads that are in common. I like that you had said that, I started the hashtag Decolonize Global Health. I definitely did not start the conversation about decolonizing global health. It's a discussion that has been existing for some time already. Even the concept of decoloniality or decolonization, there's so much literature that we in public health and in the humanitarian field should actually be reading, because there's so much to learn. There's so many definitions. Some say that decolonizing means going back to indigenous, roots, cultures, traditions. Others, for instance, from the more Latin American scholarship, they say that decoloniality is questioning or interrogating this perceived superiority and universality of Western ways of knowing, epistemology. And if you look at global health now, many people interpret it in many different ways, from how can we include more people of color, people from the global south in advisory boards, in hiring practices in global health or humanitarian organizations. How can we make sure there are not, more African sounding names in, journal publications about African health issues? And so maybe later we'll talk more about challenges that are confronting public health research, especially in humanitarian settings. So there's so many dimensions to this issue. And I think on one hand, sure, maybe it's a problem, there's no consensus. But on the other hand, I think that speaks to the diversity of, issues and challenges, and also the potential for decolonizing to be both societal, but also personal, a personal journey. Ultimately, I think we need to start decolonizing, our minds, the way we view the world, the way we always say, oh, global south, global north. Someone told me maybe we should start classifying countries according to whether they're over consuming or over polluting versus under consuming and under polluting. And so it really is also an invitation to challenge all these knowledge structures, paradigms that have been embedded for a long time, inner field, inner sector. And then finally, because I want to make sure this is a conversation, I'm sure this is more of an introduction and a provocation, what I'm giving now. You mentioned also a while ago, you called us experts. And I don't like the word expert, because I think that's actually a very colonial term, that this idea that you can actually, know and master, the wonders of the world, when in fact, especially in this day and age of, uncertainty and surprises, a lot of emerging new challenges, is there really an expert, in the 21st century? And instead of expert, maybe we should call ourselves as perpetual learners of, the phenomena that we're trying to address, whether they're natural disasters or ecological damage or health problems. I think that is less colonial and more decolonial approach to knowledge, to knowing, to learning. And so, and I guess that also has implications in the way we conduct our research. I'll stop there.
Thank you, Dr. Renzo. I would then invite Dr. Sanjuti. You've been part of two worlds. You did your doctorate from Canada, and you're currently working in Bangladesh, where you come from. So being a part of two worlds, how did you experience the whole idea and the concept of decolonization of global health? So we would like to hear your experiences for all of us to really hear what does it actually translate into. We'll be talking about terms that may mean very different to different people. So over to you.
Absolutely. Thank you so much, Farhad. And it's such a pleasure to be here. And I first want to echo what Renzo was just saying, this idea of experts and how we are not And I think the more we learn, the more we realize that we are not experts. And also the idea that, decolonizing, this idea of decolonizing or, reducing the influences that some people have over others or countries have others is not a new problem, is not an acute problem. It's a chronic, perpetual problem. And one conversation, one discussion, or a series of panel discussions is definitely not going to solve it. But I do want to thank the organizers over here that at least we're having these conversations, and we're having these conversations kind of from a perspective of Asia, which is also very, very important. Because oftentimes when I say we, I mean as a Bangladeshi, I'm based in Bangladesh, we also sometimes often forget that we had been colonized, and that the way we conduct research or global health research or public health research is still conducted in a very colonial manner. I think it's not only like the settlers or the colonizers who should remember this, it is also an education for us, and it is also the time for us to stand up and realize what we are able to do. How did I come across this entire idea of decolonizing global health, or overall the impact that it has, or neocolonialism has had in public health, is quite different than perhaps many other people who have been working in public health. I'm not from a public health background. I'm from a molecular genetics background. I worked in Canada, lived in Canada for 11 years, and then I decided to move to Bangladesh because I had this huge problem in my head of how do you connect the sophisticated experiments that you do in a laboratory in Canada for public good in a country like Bangladesh or in South Asia. And when I moved to Bangladesh, because all my memories of how hard it is to conduct research in Bangladesh were rusted. So when I moved to Bangladesh, I had all these fancy ideas of all the things that I will accomplish in Bangladesh, right? I was focused on meningitis research. I worked with the WHO. I was like, yes, I'm going to go solve this problem, do this experiment. It's going to be great. But when I started working, that is when I experienced the 1090 gap. So 1090 gap is basically the gap where we say 10% of the resources exist when 90% of the children die, or 90% of the resources exist when only 10% of the world's children die. And my experience came from trying to set up a simple sequencing facility in Bangladesh to understand what causes childhood diseases. And sequencing, genomic sequencing is very common. It's almost available in every lab in North America, Western Europe. But when we were trying to set it up in Bangladesh, we realized every barrier that we had to get through, from getting the reagents, from getting a supplier to give us the machine, to actually continuing sequencing, or even getting donors who will believe that, yes, we have the capacity to be able to do sequencing. I think that is when I realized, wait, what world are we living in? Why is it so difficult to conduct basic, simple experiments in Bangladesh, where it is needed the most? I think that's how I came across this entire idea and became an activist without realizing I was.
Thanks, Sanjyoti, and point well taken from both of you on the experts. So learning for me also. Maybe Kiran, just talking about MSF and the history we have, the places we work in. How do you see the decolonization and your experiences about what you lived, and what is the future thinking around it? If you could bring in some perspectives from the organization, because I do believe as much as we are the part of the problem, we could also be the part of the solution.
Yeah, thank you, Fahad. And thanks for the invitation to join this panel. I feel like I've already learned a lot already, and from that rapid survey of the field, I've to admit that I found the term always a bit confusing, because for me it sort of implies that, well, correctly, that global health systems were built on the back of colonialism and reproduced the same sort of structural and racial inequalities that colonialism produced. But when I hear about the discussion in MSF, it feels like we're mainly talking metaphorically. We're looking at how global health agencies, which are normally often headquartered in the north, act like colonizers, or essentially colonizers, and recipient countries or beneficiary groups, and I think there's a distinction there for humanitarian actors, are the colonized. And so when I hear about the term being used in MSF, it feels like we're sort of talking about dismantling the current global health system. But it's essentially, but looking below that, I feel that, well, we're just starting to recognize that power differentials exist in global health, and that MSF and other wealthy global health actors have huge privilege with respect to beneficiary populations, and that this results in harms. And the harms that we feel that we see are, examples such as speaking out about communities suffering without adequate consent or knowledge of those communities, as well as in some case wrongs, ethical wrongs, such as benefiting from data and testimonies from these populations, which we use to build our brand and generate income without the full knowledge of that population. So I think research, from my perspective, is one of those untaxed benefits where the privilege that we hold enables us to extract that data from the populations and potentially reinforce our own influence. I just want to say that I think one thing that's confusing, I think, in MSF is MSF and many other agencies are embarking on a laudable project to address outdated staffing models within MSF, redistributing our headquarters in a more globally equitable manner, removing barriers to management positions. Now, this is a very important and laudable process, but for me, that's about addressing a very outdated staffing model. And I keep that quite separate to the discussion on decolonizing global health. I know that they're very overlapping and some of the solutions are overlapping, but we need to keep that separate. So I think from the perspective of where I see this being at in MSF at the moment is we can't get rid of our privilege, even if we want to, even if we try and give away all our money and ask other people, ask populations to spend it. And I think also we have to acknowledge that there's no guarantee that an alternative power structure would reduce harms or exploitation in beneficial populations. And that's, of course, partly due to intersectionality. If we address the colonial dynamic, there are other dynamics that may then prevail and the situation of the vulnerable may not improve. So I think the first point for me within MSF is that we may choose to prioritize decolonizing as the emancipatory project that we want to put our effort into, maybe because we believe that all other emancipatory projects stem from that. But is that our priority? What do vulnerable people living in humanitarian settings want us to focus on? I could guess at that because I don't know if there's any evidence on that. Would communities using our services say to us, could you use your privilege in a way that brings benefit to us on our own terms and that minimizes rather than aggravates harms? Because I think one of the points there is that sometimes speaking out on behalf of a community, speaking out loudly against an injustice will be the right thing to do, especially when the people directly affected by that injustice would only endanger themselves to say so. So this, for me, it won't always mean giving up all privilege or trying to get rid of that privilege. But what it can mean, I think, when it comes to research is, can we go beyond working with populations to define priorities for health service delivery? Can we also define the research priorities together? We have done that in Russia and Belarus, and it produced some really surprising directions for research that we hadn't considered. And then I think the other thing to say is almost all MSF research involves in-country MSF investigators or authors. And 80% of our research on an audit we did involved co-investigators from the Ministry of Health, but only 20% of our research involves a local research institute. And this isn't, and does that need to change? It feels like it does, but we also have to say, well, local research institutes may be partisan to the conflict. They may deny the existence of the population we're trying to assist. Populations often trust us because we are perceived as distant from local institutions. But I think we can tend to hide behind those arguments because we do have some very good examples. And I think, can't we now start to analyze and document what it took to make those regional academic partnerships effective and show the value that they had? Because that sort of evidence would start to change the discourse in MSF. And then I think the final thing I would say is just that because the research we do in MSF and in many humanitarian agencies is operational research, it's very difficult to separate it from the program that research is informing. So can we move beyond sharing results and actually instigate measures to make ourselves accountable to affected populations, considering participatory program design and program adaptation? Because I think that's the thing. I think my final point for humanitarian settings is how to separate the research from the practice. And I'll just say that I know that none of these measures get near the final destination of decolonization, but they do mean the privileged working hard to put crisis-affected people in the driving seat as much as possible via resourceful skills or knowledge transfer. So I'll stop there. Thank you.
Thanks, Kiran. I think you mentioned something which is recently what I heard about stuck in the middle syndrome that we've been talking about. There was a review done of studies in Africa between 2014 and 16, and the authors from low and middle income countries were stuck somewhere in the middle. They were never could be the lead author, irrespective of the disease context or so. Maybe Dr. Renzo, you spoke about the paradigm shift. Maybe looking at the knowledge shift, what role do you see that could be played by the different actors in Asia when we look at it from a research perspective?
Thanks, Farhat, and thanks, Kiran, for those remarks. I'm really glad that the MSF's leadership is already really thinking about these things. I know you're doing a lot in terms of, you know, for instance, I mentioned Maria Guevara a while ago. She's been trying to position planetary health at the center of MSF's policy and operations. Over the past several years, you've had some efforts, that tried to tackle, gender discrimination, white supremacy. With all of these are really threads. That's how I see it. Threads of these whole, bag of colonial legacies that we're trying to dismantle, which then in turn result in power imbalances in contemporary time. And I really appreciate also, I'm trying to address Farhat's question, maybe tangentially, but I'm trying to also reflect on what I heard from Kiran about privilege. I think that's an issue that, and maybe Senjuti also feels the same. We even scholar practitioners who received their education from global north institutions, now coming back to our own countries, trying to build research capacity. There's always this tension between, how can I use my privilege, this world-class education, this special position that I hold in society in trying to, amplify or help amplify people's voices, raise the issues versus, and then maybe it's not really a dichotomy, maybe it's really a process, and maybe eventually we'll reach that point when, okay, I can take a step back and really provide a space for communities to voice out, their own concerns instead of I being their spokesperson. So I think, this tension should be embraced, and it's a journey that we will all need to undertake both individually and as institutions. I remember MSF's, mantra is témoignage, bearing witness. And I think ultimately that bearing witness will mean not just, witnessing and speaking up on behalf of the victims, but really creating the spaces so that the victims can voice out their concerns, their issues, their problems themselves. But thanks to our work that paved the way for that to happen. So again, it's a process. And then your question about, and maybe I've tangentially answered, very difficult question, so the tendencies you go around it. The paradigm shift for knowledge. I think, what I just said somehow speaks to that. We might feel that, okay, we need to change the system right away, 180-degree turn. Tomorrow it will be a totally decolonized culture of research. But the reality is, it will never happen overnight. It is a process and a journey. It's still about who has the money for the conduct of research, who has the capacity to be able to come up with research and publications that can be accepted by the Lancet and the New England Journal of Medicine. It also talks about it's also about who makes the decisions. And those three things alone cannot be changed or built overnight. But then we need to start somewhere. And I'm really glad, for instance, Kiran mentioned, okay, we have these metrics. only a small portion of our research done in MSF is done with local partners. Maybe the next step is to try to investigate and study how can we increase the share of the pie, considering all these other issues that you mentioned about the rigor of research, the ethics around being part of the research as well. And so again, it's a process, but we need to start from somewhere. And I think finally, it's important that we're having these discussions. It's also important that we find our peers who are also undergoing this similar journey, because the decolonizing journey is a lonely journey. You'll always face opposition. You'll always be encountering these kinds of tensions every single day. Am I being neo-colonial in trying to help others? When in fact, how I see it is I'm using my own privilege to uplift others. And so there's always this tension, again, whether at the personal or at the institutional level. But if we have this collectivity of people, fellow scholars, fellow organizations that are undergoing the same journey, I think the journey will be, will not be easy, but at least a bit, less difficult to embark on. I'll stop there.
Thank you, Renzo. We have questions coming in, but before we go to the questions, Sanjyoti, I would like you to reflect a bit more on the gender aspect of it. And then if you could share some of your experiences from that, and then any reflection related to what Kiran and Renzo spoke about.
Sure. So something I am really enjoying this panel already, right? Because, oftentimes I complain about I'm invited to these decolonizing panels, and it's like, oh, other white people in the panel. And I'm like trying to fight constantly, right? Constantly like saying these uncomfortable things, and I'm not sure how it's, sitting on them. So it's like really nice that there are people of color on this panel. And what is also really nice to hear is that we are all confused and we are all struggling internally, because this is a relatively new movement, and movement in the sense, new conversation that we are actually collectively having. And there are no right definitions, because we also don't want to define, as Renzo was saying, Dr. Kiran was saying, that really we are still trying to figure out what you're doing, and it is a process, and we're all learning. I really liked what Kiran was saying about, how decolonizing global health are two different things. If we think about MSF structure, that's one thing. And then if we are thinking about what NGOs or like organizations like MSF or other organizations are doing in the field of global health, that's a different thing. Yes, certain solutions can be applicable to both, but I think that is also very important to keep in mind. And I also want to echo privilege. We cannot give up privilege. There will always be certain imbalances in the way privilege is distributed, I guess. And the only thing we can do is like use our privilege to try to do the right thing. Now, what is the right thing? It depends on different people. Someone will use privilege one way, some others will. But the fact that we are coming together in a panel and having these discussions is, I think, really important. These are self-conversations we should also have. One question that I did want to also address is what also Kiran brought up, like, how then do we work, and especially in humanitarian settings, how do we work? Do we work with the government? Do we work with local organizations? I think there is no answer to that. We think about that too when, as an organization in Bangladesh, we're working working throughout the country at different places. I think it's impossible to have one model. I think it's always going to be different for different countries. For example, if we talk about the Rohingya population and distribution of vaccine in the Rohingya population, we can say, hey, MSF or some other NGO, don't try to come and teach us how to distribute vaccine. Bangladesh has been a world example of how to run an EPI program and how to give vaccines. So rather work with the government and distribute. That might not be the case in a different country. You can come and try to work with another local institute to help the Rohingya population. But as Kiran was saying, that's a completely different thing. Maybe they, local government or organizations might have other agenda or might not want to make certain things public, which an external organization might be able to do. I think, again, like, everything is going to be different. Again, we cannot have definitions. We cannot have global models that we will follow. It's going to be based on the context. And then I do want to bring up something about capacity building. Oftentimes, the way global health works right now is very vertical, very top down. We have these focus, like, we have to eliminate TB by 2030, let's say, or we have to eliminate malaria. And what happens is sometimes we become so focused at this one end goal, one aim that we have to reach, that we forget everything around it. We're just like focused on one pathogen or one disease. And it's very vertical. All funding comes into that vertical project. What is constantly important to remind us is, today it's TB. Tomorrow it's going to be chikungunya. The year after, or 10 years after, it's going to be hantavirus. Are we actually just solving a problem and like partially solving a problem and just creating space for another problem? Or are we actually building capacity to ensure that today I am helping this community to perhaps fight TB, but I'm ensuring that when something else comes, the community will be resilient enough, will have the capacity to take this forward and fight chikungunya. If I'm helping fight malaria today, tomorrow the community will be self-sufficient to fight dengue. So I think building capacity is really important, and it's irrespective of the setting. And when we engage local people, like humanitarian setting or just in a low middle income country, even if that setting changes, people still live in the community. People stay. They live there with those training that they can take forward and perhaps train the next generation or train other people around them. So I think building capacity constantly is very, very important to keep in mind.
Thank you. I do see some comments coming in, and I'm going to share with you and leave to the panel who wants to react on them. The first one comes from Pierre Perret, who says, not sure the use of colonization image is relevant. Colonization involves a strong notion of coercion, which does not exist in this case. And looking around at today's participants and attendants, I cannot immediately notice a strong Western cultural bias or influence. There's another comment from Seher Parsipur, who says, decolonizing global health involves dismantling structures that perpetuate the status quo and addressing unbalanced power dynamics. If one of you would like to react and reflect on this, or else I can move on to the questions. Kiran, over to you.
Well, I mean, they're two quite different perspectives. I mean, I would just say that I feel that, and also thinking back to what's been said already, we are limited in speaking from MSF point of view by our own self-awareness. I mean, I think that yes, I know, probably we would not see ourselves as coercive, and yet at the same time, I mean, COVID and Ebola have shown not just MSF, but the whole global health community, how sort of Eurocentric our knowledge system is that underpin these responses. And we only see the kind of missed opportunities and the harms afterwards. So I feel that we're limited by our own self-awareness. And I think that tackling this for MSF will mean actually developing our knowledge of the sort of socio-political and historical groundings of our practice, because essentially, yes, our model is based on the kind of Western savior bringing medical care and witnessing. And I think I'm not saying that we need to abandon that wholesale, but we need to step back and really understand the underpinnings of this. So I know that's only a tangential answer to the question, but I just feel that I think that will then help us pick this apart and say, well, what really are the priorities for us? Because it's not dismantling everything we do, but it's trying to refocus on the populations or the specific groups we're trying to help and to do that in a much more empowering way that puts people at the center. And I think, as Renzo said, I mean, not just speaking out on behalf, but actually survivor centered advocacy, actually empowering people to speak out. There will be situations where we might still need to speak out on people's behalf, but let's actually stop that as our default and make our default empowering people to speak out. And so I think just trying to really hone down to what is the change we need to make for the people that we're trying to assist, that hopefully will help us then just see, well, what do we prioritize in this huge process of decolonizing?
Okay, there's a question from an anonymous user who says, how can regional Western partnerships be built as a sustainable engagement? Does it require mentoring from the global north? Sanjyoti, it comes to you. I think you did address it a bit.
Sure. So regional can be like, just is it within Bangladesh, let's say, or is it like South Asia or Asia? And regions also vary, right? Like regional in Europe, it's very, very different than regional in Asia, where we are quite politically disconnected. The countries are disconnected. We don't have an Asian Union where we have singular aims, or like we're fighting towards the same thing. So it depends on where we are. And yes, I think it's important that we work on projects where we are able to get mentorship from the global north, right? Why are they more capable or have more infrastructure than we do right now? There are other historical causes for it. We cannot change that right now. We don't have a time machine, but right now the only way we can again use their privilege or some of us is how do we work together to move forward and transfer knowledge. So I think mentorship is really important, and we have to be open towards that.
Yep. Can I add to that about mentorship? And I want to push the boundaries even further because you mentioned a while ago, Sanjyoti, that our global North colleagues and maybe professors, leaders should be willing to mentor us, coming from the South. Interestingly, I have colleagues, younger colleagues, some even older colleagues from the North who consider me as their mentor. And so now I think from a decolonial standpoint, we should also start dismantling this idea that, those from the North should mentor the South, that it's a unidirectional kind of relationship. In fact, I remember there was a book by Sir Nigel Crisp, the former head of the National Health Service of the UK, entitled Turning the World Upside Down. What can the North learn from the South in terms of addressing some of their current their chronic challenges, in healthcare, in many other aspects. And in recent years, we've seen a lot of really good models in the global South, in developing countries, achieving same levels of, let's say, health or economic development, perhaps at a lower cost, but with so much creativity and innovation. And so I think a decolonized world will mean there is a free flow of knowledge and inspiration across countries, regardless of where you are from or whatever your status is. And also going back to the colonial literature, especially, again, as I mentioned, the one that emanated from Latin American scholarship, they always speak of the pluriversality of knowledge, that there is no single way of knowing. And unfortunately, even until today, the way we learn about global health, the research methods that we learn in master's and PhD programs, that is very Western-centric approach of knowing and conducting research. What will be a future post-COVID decolonial curriculum will include, in terms of knowledge, in terms of frameworks, in terms of research methods. I think that is very exciting to imagine.
I think I'll also add to that.
Can I bring in one question, because I think that would add, because I will not be able to do justice to the list of questions that's coming in, but I do feel this one is something that we very briefly touched earlier. Is does finance play a role in deciding the research agenda? In case Western universities fund most researchers' ongoing activities in the global South, does that dictate the research agenda suited to them? And then Kiran, for you, a question from James Smith is, what are the impediments to refocusing as you described? We are struggling to frame survivor-focused advocacy as a matter of decolonization, so reassuring to see this picking up.
Okay, so if I may start with the funding question, and I think funding is very closely interlinked with incentive, right? In some cases, funding means money. For many researchers, funding is actually kind of like the currency in research is like publishing papers or getting a promotion or getting a tenure track professorship, let's say. And the way the current incentive structure is structured is quite biased. You know, they're not built based on how many people have you trained, how much knowledge have you transferred, has your project led to bilateral benefits. So, for example, in the global north, as Renzo was saying, like even our education is really based on northern or western education system. So when someone in the global north wants to get a promotion or an university position, they will try to show how many papers they have published, right? Like that is the currency, how much grant they have been able to bring in. If there are researchers in the global north who are really, let's say, very focused on building capacity and ensuring knowledge transfer, or even someone within the global south who is helping build capacity, these are not incentivized. And at the end of the day, if you're not incentivized for what you're doing, there's no way you will move too much forward. This is not sustainable. So I think our global incentive structure in academia or research needs to change. And funding definitely has big roles because often funding is, again, vertical. They're based on one or two problems that the global north, the people who are donating the money decide or think is the problem. And we will see that although there are lots and lots of projects that are happening in the global south, whether in Africa or Asia, usually the money directly does not come to local researchers. They're usually through universities in the global north, right? So they are also like, funders are dictating what the agenda will be of that project. And then the global north is basically telling us how to implement. And oftentimes they decide what is an important pathogen or decision for us. And we don't have a lot of government funding to do our research projects. So we are also relying on that funding. Another comment that came up in the beginning is like global health, colonialism in global health is different because it's not forceful. At many times it is, because, you know, my career, my livelihood depends on how much research money I can bring in. And sometimes I have to work on a project because I know I need that research grant. So, you know, maybe not forceful physically, but definitely forceful in the way that agenda are driven.
Sanjati, given the paucity of time, I would really like Kiran to reflect on the follow-up question and already apologize to all the audience whose questions we are not able to take now, because I would like us to have one takeaway for the audience from each one of you after Kiran responds, and then an opportunity that if people have very specific questions, they can write to you and reach out to you through the launch. Over to you, Kiran.
Okay, thanks, Fahad. So I'll try and give an opinion on James's question, which was why are we struggling to frame survivor-focused advocacy as a matter of decolonization? And in a way, the question is also about why are we struggling to put people at the center and actually enable people to find their own voice? I think a lot of this is to do with the habit and the process of an emergency organization. We come into let's say a new setting with, to some extent, the medical strategy and the advocacy agenda predefined at a very high level. And we know we need to actually revisit this. And once actually the dust settles, we start to work together with people in that population to actually define these things. But we don't get round to that step quite often. And I would say the weakness in our system, and this is a very technical response, is meal. I think we're not, the monitoring, the evaluation and accountability and learning aspect of our work remains to this day weak. And I think until we're starting to measure and have metrics around accountability and people, enabling people to find their voice, it's not going to change our practice, because we're creatures of habit, and we know certain things work, or at least they produce results, and we follow that way of doing things. So I think that we need to actually start to measure how we do these things, and actually therefore sort of evaluate our own programs on the basis of the extent to which they actually put people at the center, and they enabled people to actually advocate on their own behalf.
Last 5 minutes of the meeting.
Thanks, Kiran. Thanks, Pooja, for the heads up. Before we conclude this panel discussion, I know this is now starting to heat up. We have lots of questions and comments coming in, and we can't, because of the paucity of time, take everything on board. But Rinzu, Sanjuta, and Kiran, one thing that you would like as a key takeaway for the audience to remember, to keep this conversation, not only we read about it, we discuss or reflect, how do we act on the change? So maybe one suggestion, one advice from each one of you.
Yeah. Again, thank you very much for this opportunity. And to all those who asked their questions but are feeling frustrated that they were not being asked, don't feel bad. This is just the beginning. And I think you should have a part 2 and a part 3. It's great that we started this. And the challenge now for MSF India and MSF as a whole, and the whole humanitarian global health sector as a whole, is to turn the event into a movement. And so we need to make sure this doesn't stop here, the conversation. There's so many difficult questions. And Juti said, in a way, we're still in an identity crisis, asking so many questions, very confusing, which is great. Let's embrace the tension and the confusion, because out of this, hopefully, we'll come up with clearer answers to these questions. And I think ultimately, this is a call for humility. And I think that's the ultimate message, whether you are from the north or you are from the south working for MSF, or someone who received her PhD from overseas, we all have different forms of privilege, but we need to address the issues that we've been confronting with utmost humility. And that is a challenge that we need to confront every single day. Thank you, everyone, and stay safe.
Thanks, Rinzu. Over to you, Sanjoti.
Thank you, Farhad. It's been a pleasure to be in this panel and also learn from everyone here in such a short time and come from different perspectives. I am in a very, very basic science field. And for me, what I keep on telling all my colleagues in Bangladesh or entire South Asia is, again, believing that we can. Sometimes we ourselves forget what are our capabilities. For the longest time, we have been shipping samples out for someone else to test them, or shipping pathogens out for people to sequence. But when COVID-19 came and all countries became busy with their own samples on own patients, Global North forgot about us. They were only writing a few papers without us as authors saying how bad the impact will be in India and Bangladesh. But they had forgotten where our samples are getting, how are we doing our testing, right? But we figured out in Bangladesh, we went from one lab doing COVID testing to 111 labs, from never doing any RNA virus sequencing to doing over 500 sequencing, right? So I think believing that we can, and believing that everyone should have equal access, equitable access to the practice of science and the benefits of science. I'm going to end with that. Thank you.
Thanks, Sanjoti. Over to you, Kiran.
Well, my message was going to be very similar to that, so I'll say a different one. But I think I agree absolutely about humility, and I also think it would be great to see coming out from this event an ongoing discussion, because I think an ongoing discussion would play a really useful role in driving some change in the movement with this regard. And I just want us to, and also the other thing having the ongoing discussion will do to stop this becoming tokenistic, because I see a risk with these sort of things in MSF that this becomes a sort of change managed framework type approach, and you have to tick boxes in the way you do your research. And then we've missed all the benefit of going through this discussion and going through this process, because for me, this is about recentering, and this is actually about thinking about our core values, and actually acknowledging that when we're not always meeting those values, because we're not empowering people, and we're not actually defining our projects, our plans according to needs that have been co-identified with the people we're trying to help. So I would just would like to encourage us to keep this discussion going. Thank you.
Thank you, everybody. And I think rightly said, Renzo, that we do not stop this here. We have to take it further, and it's not part 2, 3, or 4, but it's about how do we take these conversations back to our different circles and start a chain reaction. I think that's what's needed. and all the more in the humanitarian settings, because that's my ask to all of you, especially Renzo and Senjuti, to you, is we are talking about the most vulnerable populations. And as rightly kind of linked back by Renzo on the Timenage. So we are also talking about how do we create those spaces where we are necessarily just offering the role of enabler and having them in the driving seat. How do we have a research that represents the true equity and the power balance we are talking for future? It's a journey we will have to embark on, we are on, and we'll keep on continuing these conversations. Thank you, everybody, and over to you, Pooja.
Thank you so much, Dr. Saha, Dr. Ginto, Dr. Jibankotra, and Dr. Manti for such a vibrant, inspiring, and thought-provoking conversation on the inherent processes of othering caused by existing structures and systems in the field of academia generally, and humanitarian research particularly. Thank you so much. This session marks the end of day one. I would like to thank all the presenters, speakers, and panelists for sharing such wondrous insights. Today, we saw a wide range of issues and topics being discussed, from LGBT issues in India to a novel behavioral science approach for reducing violence in healthcare settings in Pakistan. From there, we moved to Afghanistan to understand some of the crucial determinants of TB care adherence. We also had the opportunity to appreciate the success of patient-centric model of care for HIV patients co-infected with hepatitis C. We were then propelled into an emotional sojourn while examining the lived experience and perceptions of palliative care among advanced HIV patients. Lastly, we reflected on the long due changes required at both ontological and epistemic levels to decolonize global health. It is through these stimulating conversations we are able to create a space where research and innovation are accessible to people in the humanitarian medical sector. These discussions would not have been possible without the participation of our presenters, speakers, and panelists who, despite being in different time zones, agreed to share their thoughts and insights in these challenging times. It has truly been a pleasure to hear all of you. I would also like to thank our audiences. Your participation and enthusiasm have made this conference a worthwhile effort.